I know the title of this is psychotropic medications. The idea is eventually this is going to include every single class of psychiatric medications. So it'd just be one PowerPoint that you guys would be able to look at and refer to. But right now it only has the antidepressants portion done. All right, so eventually this will include the antidepressants, the anxiolytics, the antipsychotics, the mood stabilizers, and the stimulants and non-stimulant medications for ADHD. I purposely put it in this order so if any of you guys ever look at the GeneSight testing results, this will line up with their genetic testing to make it a nice, easy reference guide between the two of them. So 1 in 6 Americans are on a psychiatric medication. So if we look in this room, there's 6 of you. So statistically, at least one of you guys would be on an antidepressant or some sort of psychiatric medication. Most common one used are the ADHD medications because it's the #1 diagnosed neurodevelopmental condition. But overall, there's 6 broad categories of medications used to treat a vast spectrum of antidepressants. Spectrum? I couldn't help myself. So the antidepressants. So the goal with an antidepressant is a 50% or more reduction in symptoms. I know parents and patients often think of like, I'm going to start this medication and like 2 weeks later, I'm going to have 0 symptoms. I wish that was a realistic goal, but the positive response to a medication is 50% or less. So if the person's having a panic attack every day of the week and we have it down to 3 days a week, that is considered a positive response to the medication. But I know for most people, the end goal is complete remission and to never have it happen again. But remission is typically not achieved with the first antidepressant administered, and it's something like 2/3 of people will take at least 12 months to find the right medication for them. And every antidepressant that has been FDA approved had to have at least 2/3 of people achieve 50% remission in symptoms within 8 weeks on the medication. And they're broadly classified into the MAOIs, which you'll notice like anything you ever look at has like, do not take if you're on MAOI. That's why we don't use these anymore. I'm mentioning them so you can hear the names, but we don't use them because you can't eat grapefruit, you can't drink wine, you can't eat cheese, you can't have chocolate, you're not supposed to have red meat. You're left with like chicken, a couple vegetables, and like nuts. Aside from the fact that the side effects are miserable. So we don't really use them. There's the tricyclic antidepressants. There's the selective serotonin reuptake inhibitors, or the SSRIs, that have really been the gold standard of treatment and is our first line things that we typically use. There's the serotonin norepinephrine reuptake inhibitors, or the SNRIs. Then in the newer agents, we have the norepinephrine and dopamine reuptake inhibitors, which are the NDRIs, the serotonin agonist and reuptake inhibitors, or the SARIs, and then serotonin modulators. They don't have a cool name. So the MAOIs and the TCAs were the first antidepressants that were widely available to everyone. And largely, the newer medications have taken over because they have fewer side effects, fewer interactions with other things. So it's just more tolerable for most patients to take them. The MAOIs block the monoamine oxidase enzymes. So they increase the levels of the dopamine, the norepinephrine, and the serotonin in the brain. Whereas the TCAs directly increase norepinephrine and serotonin while blocking acetylcholine and histamine receptors. And so the MAOIs that are still available are isocarbazide, Nardil and Parney. And then with the TCAs, we have amitriptyline, clomipramine, desopramine, doxepin, imipramine, nortriptyline, protriptyline, trimipramine, and then mirtazapine, but it has a little star next to it because it's technically not a TCA. That one's technically works on 4 different receptors instead of just the 3 that the tricyclics work on. And Remeron, also of this list, is the only one commonly still used today. So that's, if you only remember one, Remeron's the only one you have to remember. The SSRIs, on the other hand, work by increasing the serotonin levels by blocking the reuptake inhibitors. And so what that means is, with the brain, we have the neurons that send out the neurochemicals, and then we have the receptors that are picking up what the neurons are sending out. But let's just say this guy sends out 100 and this one needs only 75. This one is designed that it has receptors to take back some of the serotonin it's sending out. So it would pick back up the leftover 25% and then recycle it to reuse the next time it has to send some out. The reuptake inhibitors block this neuron from being able to recycle, so it can't pick up any of the stuff. So in the case of depression, one of the theories is that maybe this guy, instead of sending out 100, is now only sending out 50. This one still wants 75. So this one is trying to take the 50 that got sent out, but this one, because it has those receptors, some of them will just go the wrong direction, whatever, so it's still picking them back up. So the reuptake inhibitors block the sending neuron from being able to recycle anything. And so in this family, we have citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, and then the newest in the pack is vilazodone or Viibryd. And I'm going to go over the risks of all of these medications later, but the biggest risk with this class as a specific is that they increase bleeding. They actually increase the time it takes for the platelets to form the blood clots, so the person can actually bleed more while on these medications. The SNRIs work in a similar thing, except instead of just blocking the reuptake of the serotonin receptors, they also block the norepinephrine receptors as well. So this one's kind of a 2-punch hit. In this, we have duloxetine, desvenlafaxine, levomilazepam, and venlafaxine. All of these do have a pretty nasty discontinuation syndrome, so they're very slowly weaned off, but the one for Cymbalta is regarded as like one of the worst withdrawals that we get with any of the medications. So the NDRIs, so these work by increasing norepinephrine and dopamine by blocking the reuptake of those receptors on the sending neurons. We only have one medication in this class right now, and that's bupropion or Wellbutrin. However, they just, and I'm talking like this year, FDA approved something that is going to be the new wave of antidepressants, and these are going to be the NDMA, NDRI combo pills. Because NDMA is going to be our next wave of antidepressants, which they work on the NDMA receptor to actually upregulate it to treat depression. And so this one is Avulidy, and it's a combination of dextromethorphan, which is the DM and Robitussin DM, combined with bupropion. And actually, when used, it works in about a week, which is why this is like going to be the next wave, because these are faster acting than the traditional antidepressants that take 4 to 6 weeks to work. It works in about a week, and it can be used both by itself or in adjunct with more traditional antidepressants. And they looked specifically at treatment-resistant depression when using this one. The big bad thing about these though is if you have a history of seizures, it can make your seizures worse. So you have to do a careful seizure screening before, and if there's like a family history of seizures, warn them that if they have never been diagnosed with a seizure condition and there's a family history of them, this could trigger it and bring the seizures out. And once you have a seizure, you are immediately stopped off bupropion and you can never go back on it again. The SARIs work by both blocking the reuptake of norepinephrine and then enhance the binding of serotonin to the serotonin receptors. So it's on the one hand blocking and on the other hand enhancing. And so in this we have nifazodone and trazodone. Reality is they did not work great as treating depression. Even at very high levels, we never got the therapeutic response that we saw with the more traditional agents. However, they were really great at putting everyone to sleep. And so they're commonly used now as needed sleep aids. And the nifazodone is rarely ever used because it causes life-threatening liver failure. So one of the newer categories is the serotonin modulators. In reality, we really don't understand how these quite are working, but they somehow up-regulate the production of serotonin in the brain, while also blocking the reuptake of the serotonin as well. There's only one medicine in this family so far, and that's viroxetine or Trintellix. And just like the traditional SSRIs, this one also increases the risk of bleeding. So antidepressant warnings. So the first thing we always worry about is serotonin syndrome, because this is the most serious thing, because just like everything, it's the Goldilocks principle. Not enough serotonin is bad because then we're depressed and anxious. Too much serotonin, on the other hand, causes its own set of problems. So with serotonin syndrome, you're most likely to get it if you are on a very high dose of an SSRI. That's why you'll see a lot of times, if somebody is on like 80 milligrams of Prozac, they'll be told you can't go higher, you have to add a different medication to try to boost the effects of the serotonin, or the person will start to be weaned off that and onto something new. And that's to avoid things like serotonin syndrome. It can also happen if you mix an SSRI with high doses of alcohol, high doses of dextromethorphan. It's also common if it's mixed with things like ecstasy or mollies. There was a famous case in the, can't remember if it was the late 90s, early 2000s, where a girl, Elizabeth, was at a party scene in New York. Her dad, I believe, was the owner of the New York Times, and was out partying on her Prozac, mixed it with alcohol and ecstasy, and ended up dying. And so that's when really they started coming out with a lot of the warnings about serotonin syndrome, because the dad used all his press power owning a newspaper to make people aware of this. It starts with like agitation and confusion. It can also have sweating, tremors, they'll complain of high heart rates, but it can also lead to almost psychotic-like behavior, diarrhea. And so the thing we watch for with this is, one, warning people about mixing their medications with other drugs, and again, if they're gonna be on a cough or cold medication, not to be abusing that while they're on one of these as well. The antidepressants can also trigger a manic episode. We call it the kindling effect, where basically adding an antidepressant to a bipolar person is like adding kindling to a fire. So if a person already is diagnosed with a bipolar disorder, we'll typically not start an antidepressant unless they're already on a mood stabilizer or an antipsychotic, to manage the manic symptoms. But in our late teens or young adult population, if there's a family history of bipolar disorder, we usually make the parents aware that if they start seeing manic-like behaviors, it just might be that they've never had a manic episode before. The MAOIs, as I mentioned early, have a lot of severe drug interactions and food interactions, which is why they fell out of favor, because you really can't eat or drink anything while on them. The TCAs, the tricyclics, they can cause heart arrhythmias. They've been known to cause heart attacks, strokes, and other cardiovascular events. So usually they're kind of limited to people who have like really good cardiovascular. If there's any question, we require them to go to a cardiologist to get clearance to start one of these first. And then all the antidepressants, regardless of class, with the exception of bupropion, have a black box warning on them that I like to explain to the families. These medications do not give people suicidal thoughts, they don't put them into their heads. But people on an antidepressant are actually more likely to report that they're suicidal compared to the people on placebo. I believe the study showed that the people on the antidepressant, 1 to 2% of them were reporting their suicidal thoughts, but after 30 days, they stopped acting on those thoughts. As opposed to the kids who were on the placebo drug, 0% of them reported suicidal thoughts, but there was a 1 to 2% attempt. And this effect was mostly seen primarily in people ages 24 and under. So once people hit 25, this effect stopped being as prevalent, and actually, as the person gets older, it's seen less and less. Personally, I believe it's a benefit of the medications, because if you're telling me you have suicidal thoughts, then we can talk about them, come up with plans, do something to prevent them, as opposed to the kids not talking about them, because it makes it very hard to prevent something I don't know is happening. But when this black box warning came out, before it came out, there were a lot of kids on an antidepressant, and we were actually seeing the suicide rates and statistics going down. The rates were dropping. They came out with this, kids got pulled off the antidepressants, the suicide rate skyrocketed to the 3rd leading cause of death in the United States for ages 15 to 24, and it has since risen to the 2nd leading cause of death between ages 15 and 24. So while I do appreciate the warning being there, I also appreciate the fact that these medications were decreasing that risk prior to this warning coming out. So it's a discussion I have with anybody going on an antidepressant. And this was just a great quote. The way to get started is to quit talking and begin doing.